we have Dr. Sachin with us. He is from Chennai and heading the department. Can you give your introduction, please?
Yeah, good evening, everyone. First of all, I would like to thank Banerji sir for for inviting me to for this journal club and the Ideal Fertility Group. I am basically a medical geneticist taking care of the laboratory, genetics laboratory at Anderson Diagnostics and Labs. We have been doing prenatal genetic testing from past 8 years. Not only prenatal, we are also in the pre-implantation genetic testing and male and female infertility testing. So today's topic of the discussion, D'Pankar Banerji sir will be discussing of it across. I will try to solve as much as possible whatever the genetic side we can sort out the issues. Thank you sir for the invitation.
Thank you, Dr. Sachin, and I am having with me Dr. Ashita also, my fellow, and she has a lot of questions regarding genetics and daily routine practice. Do you want to say something? So she will be asking questions when we deal day-to-day IVF with reproductive medicine, with fetal medicine. So I'm opening this session with a talk rather than I am demonstrating the things in whiteboard. She had a question that, can you repeat that question?
My question was that we have two options for confirming the diagnosis of the baby, whether what disorder the baby has. It's amniocentesis and CVS. Now what happens that if suppose a patient knows that they are carrier for specific, and there is another option where the patient doesn't know that they are carriers, they come to know after they are pregnant or late in pregnancy. So CVS is done in 3 months and amniocentesis at 4 months. So what happens with patients who have had a previous scar or previous uterine surgery, such as previous cesarean sections, 2 previous cesarean sections. अब इनको 4th month में when we tell them कि we diagnose them, and जब तक उनको पता चलेगा रिपोर्ट आएगा वो 18 weeks 20 weeks हो जाता है. तो at that time patient with a previous 2 cesarean or 1 cesarean वो pregnancy को terminate करना is very difficult. It has a high risk of complications, uterine rupture also, and many a times directly operate करके ही termination करना पड़ता है. It is not possible to vaginally deliver the patient. So unnecessary the patient will get another scar. जो चीज initially 3rd month में करके we could have had a vaginally termination possible. So why don't we prefer CVS for these patients rather than going for amniocentesis?
So Sachin, I will, as a clinician, I will be touching this topic today, and whatever questions we have regarding chorion or amniotic fluid genetics, we will ask you that question, and I will open this session with clinical application, what she has asked, and then we will discuss. Please be seated. Okay. Ashita asked a very pertinent question, and this is being a gynecologist. Very pertinent. Why? Because if I do a prenatal diagnostic test, which makes the decision making for the couple quite late in pregnancy, then if there is no scar or if there is no previous pregnancies by cesarean section or delivery by cesarean section, most of the time no problem. But being a clinician, when the patient comes to me or to her, to any gynecologist, with a previous scar here, 1 or sometimes 2, and then I diagnose it as 16 weeks, and then report comes after 1 week, so the pregnancy goes to 17 to 18 weeks. मतलब आप 4 से 5 महीने के आसपास चले जा रहे हो. इस प्रेगनेंसी को बच्चा ठीक है कि नहीं वो देखने के लिए. आफ्टर दैट इफ देर इज अ प्रॉब्लम, देन इफ थैलेसीमिया मेजर और सिकल सेल डिजीज और एनी इनबॉर्न एरर ऑफ मेटाबॉलिज्म कुछ भी हो, अब कपल के ऊपर है कि ये रखना है कि नहीं रखना. मोस्ट ऑफ द टाइम इफ द बेबी इज इन वेरी हायर ग्रेड ऑफ डिजीज status, they don't want, then this termination is very difficult because there is a scar. Now if we do a delivery sort of thing, there will be tension here, there might यहाँ पर ये rupture भी हो सकता है. इसको बचाने के लिए कई बार हमको रिपीट हिस्टेरोटमी या रिपीट ऑपरेशन करना पड़ता है. आई थिंक दिस इज द क्वेश्चन. Why I am putting this talk? Because I want to put a message across that yes, we can do it early also. How? आप यदि प्रेगनेंसी को देखोगे तो प्रेगनेंसी में दो पार्ट, एक प्लेसेंटा रहता है और एक बेबी रहता है. दिस बेबीज कॉर्ड इज अटैच्ड टू दिस प्लेसेंटा और ये एक एमनियोटिक सैक में रहता है. दिस प्लेसेंटल सेल, इसको कोरियन भी बोलते हैं, मैक्सिमम ऑफ द टाइम, दैट इज दिस रिप्रेजेंट्स दिस. सो हम यदि इसका भी सैंपल निकाल लें तो इसका जो रिजल्ट होगा दैट विल बी बेबीज रिजल्ट. There are two methods of doing prenatal diagnosis. हम डायग्नोसिस क्यों कर रहे हैं? दो कारण से. ये इंपॉर्टेंट है बहुत जानना. ये प्रेगनेंसी, हमारे पास प्रेग्नेंट वुमेन आई, दो प्रकार के आते हैं. एक होता है जिसके खानदान में कोई बीमारी नहीं थी, देयर इज नो डिजीज इन हर फैमिली और हस्बैंड्स फैमिली, and she gets a pregnancy and she is coming here for, there is Down syndrome है कि नहीं वो देखने के लिए, और कोई एन्यूप्लॉइडी है कि नहीं देखने के लिए. ये ठीक वैसा ही है कि हमको मालूम नहीं कि बेबी में प्रॉब्लम है कि नहीं, तो हम बेबी में प्रॉब्लम जो मेजर अधिकतर होता है उसको देखना चाहते हैं. अदरवाइज इसकी फैमिली में ऐसा कोई डिजीज नहीं है. एक दूसरी फैमिली आती है, दूसरी प्रेग्नेंट लेडी आती है जिसके घर में पीढ़ियों में हो सकता है ये खुद कैरियर हो या फिर कहीं पर इनका बीमारी वाला कोई रिश्तेदार हो, इसके तरफ या इसके तरफ. दैट मीन्स इस लेडी में प्रेगनेंसी में डाउन सिंड्रोम के खतरे के अलावा उसको मेजर खतरा इस बीमारी का है. ऐसी बीमारी जो कि पेरेंट से बच्चे में आ सकती है, उसको जेनेटिक डिजीज बोलते हैं. इसका मतलब टू टाइप्स ऑफ पेशेंट्स आर कमिंग टू मी. तो मैं एक में जेनेटिक डिजीज खोजूंगा और एक में डाउन सिंड्रोम खोजूंगा. अब मैं इसको कितना जल्दी, इसमें ये जो यूट्रस है इसके भीतर जो बेबी है वो बेबी में डाउन सिंड्रोम का खतरा इस तरफ से है कि नहीं, यदि नहीं है तो कंटिन्यू कर लो. यदि जेनेटिक डिजीज इधर से नहीं है तो कंटिन्यू कर लो. तो ये बच्चा इस बीमारी से डिजीज्ड है कि नहीं, या फिर इसको एन्यूप्लॉइडी या कोई दूसरा जो कि घर में नहीं था अचानक हो सकता है, उसको देखने के लिए यदि सब ठीक है तो कंटिन्यू कर लो. ये जो कंटिन्यू कर लो बोलते हैं, कंटिन्यू द प्रेगनेंसी, वी हैव टू डू अ डायग्नोस्टिक टेस्ट. इधर पे हम कैसे पकड़ते हैं? स्क्रीनिंग टेस्ट से. दीज स्क्रीनिंग टेस्ट आर डन बाय मैटरनल ब्लड, दैट इज डबल मार्कर, और हम एक एंटी स्कैन करते हैं. ये हम कब कर रहे हैं? 11 वीक से 12 वीक्स, मतलब 3 महीने में. अब 3 महीने में यदि इफ देयर इज हाई रिस्क रिजल्ट, मतलब बच्चे में खतरा है कि डाउन सिंड्रोम होगा। अब इस खतरे को बच्चे में देखने के लिए मैं उसको यदि 12 हफ्ते में 3 महीने में बोलूं खतरा है, इफ देयर इज ए हाई रिस्क ऑफ द बेबी ऑफ अफेक्टिंग बाय डाउन सिंड्रोम, and then ask her to wait for 4th month for amniocentesis. Why? Because amniocentesis में हमको इसके चारों तरफ जो फ्लूइड है उसमें से सेल मिलेंगे, तो सेल आर फ्रॉम बेबी, वी कैन टेक DNA, so it will be a DNA test of the baby which will be confirmatory. Now if I ask her to wait for 1 month, then things will be difficult for her to wait for 1 month to get confirmed कि उसको डाउन सिंड्रोम है कि नहीं। भगवान ना करे यदि है तो उसको रखना है कि नहीं, तो आप उसको 1 महीने डिले करा रहे हो। सेम थिंग इफ देयर इज बीमारी इन देयर फैमिली, ये बीमारी सिकल सेल भी हो सकती है, ये बीमारी थैलेसीमिया भी हो सकती है, ये बीमारी डूशेन मस्कुलर डिस्ट्रॉफी भी हो सकती है, इनबॉर्न एरर ऑफ मेटाबॉलिज्म भी हो सकती है, कुछ भी हो सकती है जो कि ऑटोसोमल रिसेसिव या फिर आधा यदि खराब हो तो पेशेंट ठीक रहता है, चल जाता है, बट यदि दोनों खराब मिलके यदि बच्चा बनाए तो बच्चा जो होगा वो बीमार होगा। अब इस बीमारी को भी पक्का करने के लिए इफ आई वेट फॉर 4th month, तो यू कैन अंडरस्टैंड up to that level the lady has to undergo this waiting, and she will be how much worried, the couple. Can we do this test here for Down syndrome confirmation and here for genetic disease confirmation? How we can do it? How? When there is pregnancy, the baby is inside the womb and it is surrounded by some tissue which is attached, जो कि मदर के साथ अटैच होता है, उसको बोलते हैं, जिससे प्लेसेंटा बनेगा, उसको बोलते हैं कोरियोनिक टिश्यू। यदि मैं 3rd month में इसका सैंपल ले लूं, क्योंकि 3rd month में आप ये पानी निकाल के टेस्ट नहीं कर सकते, बच्चे को प्रॉब्लम होती है, लिम्ब डिफेक्ट्स हो सकते हैं, प्लस इसमें सेल कम रहते हैं, तो आपको रिपोर्ट मिलने में भी कई बार टाइम लगता है ना सचिन। व्हाट हैपेंस इफ यू डू अर्ली एमनियोसेंटेसिस? समटाइम्स यू हैव टू कल्चर इट।
ये होता है कि अगर हम लोग एमनियोटिक फ्लूइड, वी हैव सीन certain samples they collected 14 weeks, 15 weeks. Then what will happen is at that certain time what happens is we try to extract the DNA for the molecular testing, but the DNA concentration will be lesser. So क्योंकि एमनियोसाइट्स, एमनियोटिक फ्लूइड में जो सेल्स रहते हैं उसको एमनियोसाइट्स बोलकर बोलते हैं, ये एमनियोसाइट्स कम रहने से वजह से हम लोग को डीएनए कम मिलता है, क्योंकि हम लोग को रिक्वायर्ड अमाउंट दिस मच ऑफ डीएनए चाहिए हमको। अगर वो नहीं रहा तो हम लोग सेल्स को ग्रो करना पड़ेगा, इन विट्रो ग्रो करके, ताकि हमको सफिशिएंट नंबर सेल्स लेके, बट ये ग्रो करने के लिए एटलीस्ट उनको 10 से 12 दिन चाहिए एक्स्ट्रा। सो अगेन पेशेंट वेटिंग पीरियड भी ज्यादा हो जाएगा, डायग्नोसिस भी डिले हो जाएगा।
That means the answer is not amniocentesis at 12 weeks or 14 weeks.
14 weeks.
The answer is that you should do a sample of the chorion, that is called chorion villus sampling.
They have also found that early amniocentesis is associated with more limb defects and
Limb defects. So it is better not to do. It is abandoned before 16 weeks. So it is a better to do at 16 weeks. तो आप 16 weeks मतलब 4 महीने तक उसको वेट कर रहे हैं। what I started now, Sachin, is that we are preferring to do chorionic villus sampling at 3rd month.
Okay.
This 3rd month chorionic villus sampling under ultrasound guide, we can get trophoblastic cell DNA, which is same as fetal DNA, barring 1 to 2% of difference, rather 1 to 1.5% difference हो सकता है, very rarely.
Correct. Exactly.
So 98.5% will be the same till up to 99% will be the same with the baby.
Exactly.
That means मैं यदि कोरियन विलस सैम्पलिंग का सेल निकाल के आपको दूं, then you can do the test of aneuploidy or genetic test and we can get the result within 10 to 15 days. If it is an aneuploidy test, we can get it within 7 days. So आप maximum 13 weeks to 14 weeks मतलब 2.25 महीने से 2.5 महीने के 3.25 महीने से 3.5 महीने के बीच में you are free.
Yes, free from the
Which is actually happening at amniocentesis at 18 weeks sometimes.
16 to 18 weeks kind of thing.
If this is the thing which we can do, so what may be the problem, how this happens? This Korean villus sampling is more better for genetic disease diagnosis, but for aneuploidy test, it is 99%, 98.5% correct. It is correct.
Yes.
Now, when we do this thing for genetic disorder, so there are 2 types of disorders we are finding. One is Down syndrome. Down syndrome मतलब chromosomal defect, aneuploidy. That means पूरा का पूरा क्रोमोसोम एक एक्स्ट्रा 21 वाला जुड़ रहा. This extra chromosome, when we do in chorion biopsy, we get 2 types of cells. One is core and one is, this is cytotrophoblast and it is covered by syncytiotrophoblast. This cytotrophoblast is coming from trophoblast cell. ट्रोफोब्लास्ट से प्लेसेंटा बनता है. ट्रोफोब्लास्ट क्या होता है, यदि आप ब्लास्टोसिस्ट देखोगे तो इसमें जो आउटर सेल रहता है और भीतर एक इनर सेल मास रहता है, दिस मेक्स द बेबी एंड दिस मेक्स द ट्रोफोब्लास्ट. ट्रोफोब्लास्ट में और इनर सेल मास में ये डिफरेंस, फुल क्रोमोसोम का डिफरेंस होना माइट बी 1 to 1.5% हो सकता है. बट इसका जो कोर है, यदि हम इस कोर का लॉन्ग टर्म कल्चर करें, इट इज सेम एज इनर सेल मास. ये कैसे होता है, आई एम नॉट गोइंग इनटू दैट डिटेल, बट ये और बच्चे का डिस्क्रिपेंसी होने का चांस वेरी वेरी लेस. एम आई करेक्ट?
Yes.
If this discrepancy is there, or there might be 2 group of cells in trophoblast which might be having, some might be having 47, some might be having 46. If this 2 type of cell we get, this is called mosaicism. This mosaicism come actual rate is 1 to 1.5%. Now, if we get this mosaicism very unfortunately, which happened with our one case, I think in thousands I get one case.
Yes. See,
We did, इस केस में हमने amniocentesis किया to confirm whether baby is actually mosaic or not.
exactly.
And baby came
Normal.
normal.
Correct. I think it was chromosome number 7.
7.
And we have also seen that this chromosome 7 always gives false positives whenever we are doing the NIPTs also. Like most of the time I get a NIPT positive, which is a cell-free DNA kind of a thing. And when we are taking a cell-free DNA, the chances of chromosome 7 coming out to be a positive is most of the time 99% it's a false positive, because 14 to 15 weeks of the pregnancy, chromosome 7 abnormality will never ever
Survive. That is very important.
So we felt that okay, it's a false positive, better to reassure, do an amnio and reassure that everything seems to be a normal one.
This is a very, very important statement, that if there is a mosaicism regarding extra chromosome, this 47, उसमें जो extra chromosome जो number 7 आया था, this 7 number का chromosome, if it is happening in inner cell mass or in baby, usually, mostly it is not surviving. It is a blighted ovum. Trisomy 16 is a blighted ovum. Trisomy 7 is a blighted ovum. So what Sachin was telling me, that NIPT में यदि ये चीज extra मिलती है 7, this NIPT is cell-free fetal DNA which is coming from cytotrophoblast. So this trophoblast might have mosaicism. Trophoblast might have mosaicism, which is a false positive mosaic. If it is actually have been with the baby, it would have been blighted ovum. तो आप यदि ब्लाइटेड ओवम है तो फिर ये सब करने की जरूरत ही नहीं है. और यदि बेबी हमको अल्ट्रासाउंड में, सचिन, यदि आई एम गेटिंग अ गुड एंटी ड्यूरिंग एंटी, द बेबी इज एब्सोल्युटली ओके विथ एनाटॉमी एंड विथ, देन चांसेस ऑफ हैविंग ट्राइसोमी 7 इज रूल्ड आउट. तो उसको लेके बहुत टेंशन नहीं करते. इसका मतलब हम कोरियन बायोप्सी में इजीली कंफर्मेटरी टेस्ट कर सकते. अभी रिसेंटली जो पेपर आया है फ्रॉम लिंचिटी फ्रॉम इंग्लैंड, they have harvested these cells from the inner core also.
Correct.
This core cells, I don't know how to separate trophoblast from the mesenchymal core. You told me that it is a cell harvesting method.
Cell harvesting method. Correct.
So if this cell can be harvested, then this genetic will be same as inner cell mass or baby. अब यदि इसमें इतना कम डिफरेंस में हम रिजल्ट कंफर्मेटरी दे सकते हैं, देन व्हाई नॉट टू डू सीवीएस एट 3 मंथ. अब पूछेंगे कि सीवीएस जब हम करेंगे तो यहां से जब हम सैंपल निकालेंगे तो कैसे निकालेंगे? दिस इज अ क्लिनिकल क्वेश्चन. क्या इसमें एबॉर्शन का खतरा एमनियोसेंटेसिस से जैसे है कि ज्यादा है? अभी तक जितने भी लोगों ने एमनियोसेंटेसिस और कोरियन बायोप्सी किया है, द खतरा ऑफ गेटिंग एन एबॉर्शन इज 1000 में 1 या 2. प्रेगनेंसी कॉम्प्लिकेशन विथ सीवीएस एंड प्रेगनेंसी कॉम्प्लिकेशन विथ एमनियोसेंटेसिस इज सेम एंड इट इज इन प्रूवन नाउ. बट सीवीएस विल बी लिटिल बिट टेक्निकली चैलेंजिंग, because you need an ultrasound guided needle. यहाँ पर needle यहाँ नहीं जाना चाहिए. So we did CVS for most of the time for the genetic disorders.
Yes.
And I think you get good samples and
Yes.
you get result
Good
within
amount
10
of villi also.
So ये जो विलाई निकलेगा, इस विलाई में आप जब देखोगे तो there are 2 things we need to test this chorionic villi. One is for aneuploidy, जिसमें कि घर में कोई बीमारी नहीं थी, and we want to check the baby if the pregnancy came high risk in double marker and high risk with combined first trimester screening. So combined first trimester screening contains double marker, that is PAP A and free beta HCG. इसका एक बायोकेमिकल टेस्ट प्लस एंटी, इनका कुल मिला के जो टेस्ट आपको सॉफ्टवेयर करके देती है, दैट इज इफ इट इज लेस देन 1 out of 250, देन वी कॉल इट हाई रिस्क. अब क्या इसमें हम एनआईपीटी करा के देख लें कि ये पक्का है कि नहीं? नहीं, बिकॉज एनआईपीटी इज स्टिल अ स्क्रीनिंग टेस्ट. इट इज बेटर टू गो फॉर डायग्नोस्टिक टेस्ट जो इंग्लैंड में जो चलता है दैट इज 1/100 एंड कितना है 1/100 हाई रिस्क और 1/1000 के बीच में इज इंटरमीडिएट रिस्क एंड 1/more than 1/1000 यदि हुआ तो लो रिस्क. दिस इज वेरी कंफ्यूजिंग समटाइम्स
Correct.
बिकॉज व्हाट यू विल डू विद द वन जिसमें लो रिस्क, इसमें इंटरमीडिएट रिस्क बता दिया. Then they say you do a NIPT, which again a screening test. So patient gets confused. So whenever there is confusion, better to go for a diagnostic test.
You need it.
This is one of the thing which is happening with the aneuploidy matter, which जिसमें कि हमारे घर में कोई बीमारी नहीं थी, हम बच्चे में, फिर से मैं बोल रहा हूँ, मैं दो चीज लेके चल रहा हूँ. वन इज डाउन सिंड्रोम कंबाइंड, फर्स्ट ट्राइमेस्टर स्क्रीन पॉजिटिव आया. पेशेंट परेशान हो जाता है कि वास्तव में मेरे बच्चे में डाउन सिंड्रोम या फिर एन्यूप्लॉइडी है कि नहीं, हमको पक्का बताइए. अब पक्का बताने के लिए 1 महीना वेट कराओ तो वो 1 महीना बड़ा मुश्किल से कटता है. तो बेटर यू डू. सो व्हाट आई डू नाउअडेज, पहले मैं केवल जो जेनेटिक डिजीज वाला बीमारी था, आई डू CVS for as early as possible. Why this test will be good? Because here there might be some mosaicism of the full chromosome, but here we want to see the gene within the chromosome. That means इसके भीतर जो जीन है वो देखना है. ये जीन यदि मैं इसको ऐसा बोलूं, it is good and this is bad. Even though if this chromosome becomes extra, this gene pattern will not change. So if both the chromosome from mother and father in the baby contains bad gene both in that is then a disease status. If one is normal, one is abnormal, then it is a carrier status. You can continue the pregnancy. If both are good, then you are lucky. So this test by CVS is not for whole chromosome. So thinking about aneuploidy is out. Either gene will be tested if it is good or wild variety, or it is a mutant bad variety. If both are bad, disease will be there. Sickle cell disease will be there. Thalassemia major will be there. So आप इससे क्या कर सकते हो कि आप उस प्रेगनेंसी में जिसमें दोनों, जैसे आज ही हमने जो एमनियोसेंटेसिस किया, because patient came late.
Yeah, most of the time it happens.
So I did a amniocentesis and now testing for the one patient, this sickle cell के लिए आई थी. इस sickle cell का जीन जो है वो खराब sickle cell है कि नहीं, the lab will test and they will say whether baby is having sickle cell disease or not. Same thing for any genetic disorder, we can prevent it. Basically हम एक अभियान से जुड़े हैं जिसमें हम थैलेसीमिया और सिकल सेल को आने से रोक सकें. ऐसे ही यदि किसी घर में किसी भी तरह का कोई ऐसा डिजीज चल रहा हो, स्पाइनल मस्कुलर एट्रोफी भी एक बहुत कॉमन
है इंडिया में.
These diseases, they appear suddenly, but if you know there are carriers in the family, then please you can prevent it by at 3rd month. So we are doing Chorion biopsy nowadays for preventing and identifying, diagnosing, पक्का करने का बीमारी है कि नहीं बेबी में, ताकि प्रेगनेंसी को आगे बढ़ाना कि नहीं बढ़ाना वो कपल के ऊपर है, पर हम एटलीस्ट उनको बता सकते हैं कि आपके बच्चे का स्टेटस क्या है. सेम थिंग इफ देयर इज अ डबल मार्कर और कंबाइंड फीटल स्क्रीनिंग में बेबी इज हाई रिस्क, देन यू कैन गो फॉर कोरियन बायोप्सी एट 3rd month and confirm without having too much botheration for मोजाइसिज्म, बिकॉज ऐसे मोजाइक जिसमें कि क्रोमोसोम 7 का प्रॉब्लम हो तो वो आर्टिफैक्ट्स हैं, वो नॉर्मली बेबी में नहीं रहते. यदि वैसा कुछ आता है जो एक केस में हुआ था, वी कैन very rarely we need amniocentesis to confirm even the baby looks normal. I think my message is that do CVS. We are doing CVS at 3rd month and try to give that result for aneuploidy screening and for genetic disease diagnosis as early as possible so that the couple can take a decision. I think chair यहाँ पे we can आजा पास में. We have geneticist with us and अभी one case came, मतलब मैं आपको उसका एक what I want to say that she was with me and we got a patient from Patna. तो मैं ये भी एक मैसेज देना चाहता हूँ. There is a family, suddenly they got a child, even though they have undergone ultrasound and all, but unfortunately they delivered a down baby. So this girl child is I think कितने साल की होगी? 3 साल की है. Because of that, they were worried and she get another pregnancy, and unfortunately, she came as high risk combined.
First trimester combined high risk.
Okay.
Because of anxiety, fear, because of fear, aborted the baby without doing diagnostic test.
Without doing it.
And when product of conception somebody advised, I think, no,
Fish was done.
there is no aneuploidy.
Okay.
So this is a message कि आप स्क्रीनिंग टेस्ट पे या NIPT पे जाके खाली अपने डिसीजन मत लीजिए. गो विद द डायग्नोस्टिक टेस्ट. ऐसा उसके साथ 2 बार हो गया.
Why she conceived and got aborted?
Aborted because of the anxiety.
And what happens sometimes, there are a lot of things which are human interference in doing the test. So there might be, the software doesn't know, whatever you put, it will give the result.
Exactly.
So both of the time it is.
And moreover, it is an indirect based test, just measuring the hormone. We are not able to tell it across. So that's the challenge.
So what happened that she got 1 down child with her and 2 abortion without knowing the confirmatory test. So हम ये भी बोलना चाहते हैं कि आप खाली हाई रिस्क डबल मार्कर या हाई रिस्क फर्स्ट ट्राइमेस्टर कंबाइंड स्क्रीनिंग में आप इतना मत डरिए कि आपका बेबी खराब ही होने वाला है.
और इस तरह पेशेंट को व्हाट आई आल्सो रिकमेंड इज ट्राई टू डू अ कपल कैरियोटाइपिंग आल्सो. प्रोबेबली ये जो डाउन सिंड्रोम का बेबी उनके पास है, शायद 21 ट्रांसलोकेशन हो सकता है पेशेंट को. बैलेंस्ड कैरियर रहे तो देयर वुड बी अ रिस्क ऑफ अगेन कमिंग ऑफ ए डाउन सिंड्रोम बेबी. सो ये जो 21 ट्रांसलोकेशन बहुत कॉमन होता है कि ट्राइसोमी 21 फिर से आ सकता है, क्योंकि डाउन सिंड्रोम आइदर इट वुड बी एन इनहेरिटेड और द डी नोवो.
Yes.
To be on the safer side, do a karyotyping, because already she has lost 2 babies and already she has this one. And do an amnio or a CVS, look for the translocation culture based testing across.
So what I do, Sachin, if I get this down baby, then I try to do, if it is possible, the chromosomal analysis of the living child.
Correct. Exactly.
So if it is a trisomy, it is not a translocation, then we rule out the translocation things in parents.
Parents, correct. Exactly right.
So the trisomy recurrence is lesser.
Lesser, correct. No doubt about it.
But if there is translocation between 2 chromosomes, they got united with 21 and anyone, either 14 or 21 or 22. If 21 if got attached, and then the risk will be very high.
Yeah, yes, exactly.
And the second thing is, has been told that if the baby is Down syndrome in first pregnancy, the chances of having Down syndrome in the second pregnancy will be 0.75% more, rather 1% more.
1% more.
So what I suggest is straightforward, go for diagnostic test.
No doubt about it. Yes.
So these things are very important, and if baby looks anatomically normal and the double marker comes abnormal and total with age, with biochemistry and with anti-scan it becomes high risk, then definitely what I prefer is still is not doing NIPT to confirm. In some countries they are propagating it.
Yes. Yes.
But I don't feel that it is prudent to do another screening test to confirm some screening test. Better to do a confirmatory.
Confirmatory test.
High risk, and they are advising NIPT earlier. Rather straight away going for diagnostic test. Because
But
that will
the
also
problem,
give us
but the
risk.
as a gynecologist, if you ask your patient to go for Chorion biopsy and amniocentesis like invasive test, what is the usual response you get from the patients?
First thing is they're scared that why should I do it?
Hmm.
Secondly, the fear that something might happen to the child. Then thirdly, cost also. They're also worried about the cost, that why do I have to undergo such an expensive test? And these are the three things that they mostly fear.
Regarding the fear of abortion, how much fear usually your patient group had?
Everybody has to be counseled. I mean, not a single patient will be like, okay, I can. They will be scared. They're very much scared of putting a needle inside the uterus. They're very much
Don't you
scared of
feel
it.
even the gynecologists are not primed and they are
Yes,
careful
as well.
that
When we undergo training for 3 years, because every center doesn't have a fetal medicine wing or fetal medicine hospital attached, so we are also not exposed to it. So even we are scared because we've not seen it frequently. The more you see it, the more you become adapted to it. So if you're not seeing it, then it becomes scary.
And a lot of people are saying about the NIPT, but NIPT also has a clause. We should always remember one thing. NIPT has a false negative rates of 1 in 10,000. Now, which is that 1 in 10,000 rate? Because I have seen in my career where the NIPT comes out to be absolutely normal and the baby is born with the Down syndrome. NIPT अच्छा है, ठीक है, चलेगा, pregnancy continue करेंगे, but baby is born with the Down syndrome. In that kind of a scenario, it really scares, because when the baby is an abnormal baby,
Yeah,
so that becomes real challenge.
This is also another question that if like we advise NIPT for a patient. So if NIPT is abnormal, so many a times I've seen patient directly going in for termination.
Yeah, that is, I have seen, especially in the tier 2, tier 3 cities, where it's all about, I think, what sir said, like a propaganda for the NIPT and this one, because they want to promote and
What
they
is
want
the
to
false positive rate for NIPT? That's what I want to ask.
False positive rate. I was telling about the chromosome number 7, right? That kind of a thing across. Now there are different methods of NIPT which tells about the different false positive, but in my opinion, if whether you do whichever S&P counting based or whether you do the parallel sequence, massive parallel sequencing based, this one is one and the same only. The false positive rate hardly is around 1 to 2%. Again, it depends upon the what kind of a chromosomes you are looking into it.
Like if we get a trisomy 21 or 18, which is common, in which the baby survives actually.
Okay.
So what can be the false positive rate in that?
In my opinion, like in my experience, what I have seen is until now I have seen false positive of 2 cases of almost, we are done close to around 10,000 cases. So we have seen false positive for trisomy 21.
So my answer as a clinician is what she is talking about, that we with branded bunches of company, they are coming with NIPT tests and all. They always say it is sensitivity is 99%.
That is only for trisomy 21.
I am again here again, because sensitivity doesn't mean positive predictive value.
Exactly. When you are talking about PPV, it is totally different. Sensitivity word is totally different.
So what Ashita was telling, she actually, what clinician wants. Clinician and obstetrician, they are dealing with the pregnant women.
Difficult to tell somebody whether you should terminate or not. They are going to rely on you.
Directly straight across with that one.
हम क्या करें?
तो इसका जो आंसर है ना, वो आंसर मैं इसलिए देना चाहता हूँ बार बार, कि जो कंपनी आती है ना हमारे पास में, वो ये बोलती है, इवन आप किताब उठाएंगे तो उसमें आपको 99% सेंसिटिविटी वाला वर्ड यूज होगा. जब ये यूज होगा, इसका मतलब यदि कोई 25 इयर्स की लेडी, उसका यदि NIPT पॉजिटिव आया, तो उसका 99% सेंसिटिविटी की जगह एक्चुअल ग्राउंड में पॉजिटिव होना इज ओनली 50 to 55%. दैट मीन्स जो आप पूछ रही हो ना कि इसका फॉल्स पॉजिटिव रेट प्रेग्नेंट वुमेन जितनी यंग होगी उतना उसका फॉल्स पॉजिटिव रेट ज़्यादा होगा, पॉजिटिव प्रिडिक्टिव वैल्यू कम होगी. इवन दो दे से दिस इज अ वेरी सेंसिटिव टेस्ट टू कैच ट्राइसोमी 21, up to 97% trisomy 18, up to 96% rather in trisomy 13. And still it is not a very good test for X and Y aneuploidy.
I think it's almost like 50% tossing a coin. So that is something challenge.
आप जब उस पेशेंट का कंबाइंड स्क्रीनिंग करा रहे हो, तो जब हम कंबाइंड स्क्रीनिंग अच्छे से करें तो डिटेक्शन रेट with good analysis, with age priori and with good anti scan यदि आप कर रहे हो, तो आपकी उसकी डिटेक्शन रेट्स 80-85% तक जाती है, इवन 92% तक जा सकती है. इवन दो this sensitivity or detection rate goes to up to 90-92%, it doesn't mean it has a positive predictive value of 90%. It has a tremendous amount of false positive rates. सो कभी भी आप ऐसे टेस्ट जिसमें आप डायरेक्ट सेल नहीं निकाले, डायरेक्ट फीटल DNA नहीं निकाले, उस टेस्ट को आप डायग्नोस्टिक बोल ही नहीं सकते. और आपको ये केवल एक स्क्रीनिंग टेस्ट के रूप में लिया जाता है, बिकॉज जैसे कि व्हाट चिन्मयी टोल्ड ड्यूरिंग हर लेक्चर, जब वो आई थी हमारे यहाँ, एंड उसके एक किताब में भी उसने लिखा, वेरी नाइस एनालॉजी, दैट when you embark on aircraft, when you enter into the airport, your baggage are checked for bomb.
Correct.
For dangerous elements.
Correct.
And they scan every suitcase.
Correct.
As if you are disturbing or you do something wrong. So all babies are closed suitcase.
Exactly. Right.
And the scanning method is age. Scanning method is biochemistry of the mother, and scanning method is ultrasound or anti-scan of the pregnancy. If that person feels that there is something which is looking suspicious, then they hold the suitcase and they open it. Opening the suitcase is diagnosis. So entering a needle into the fluid or taking a chorion and then test is for the what you have suspected. If it is not there, go ahead. If it is there, then you cannot embark, you cannot board.
Exactly.
So this is the same thing is happening. और एक चीज बहुत इंपॉर्टेंट जो अमेरिकन कॉलेज ऑफ ऑब्स्टेटिक गायनी बोली है, दैट इज the whole world, the whole gynec arena, whole obstetrician like her, we are all worried about Down syndrome. I think Down syndrome is the third category, third variety is the commonest problem in neonates. The first problem is cardiac. Second is neural tube defect. Then Down syndrome. Another very important thing, whole chromosomal aneuploidy is lesser common than submicroscopic deletion and duplication.
Correct.
Now, what is that? It is not a whole chromosome aneuploidy. It is the part of the chromosome which is not visible in microscope. That is copy number variation. If some part of the gene is included in that deleted or duplicated part, there will be different in genetic dosage of that protein. That might create problem, even though the baby is not suffering from aneuploidy or Down syndrome. The total number of chromosome will be okay, but there are intrachromosomal deletion which is not visible in microscope is present, which might contain a very important gene.
Microdeletion syndromes.
So microdeletion syndrome overall is 1%.
1%, yes.
That means all patients, all pregnant women are 1 out of 100 at risk.
Correct.
ठीक, तो हमको ये बोला जाता है कि 1 in 250 के नीचे आप डायग्नोस्टिक टेस्ट करो, तो आपका तो हर प्रेगनेंसी 1 out of 100 के नीचे है. That means every pregnancy, all suitcases should be open. And this is the scene in world that you offer every woman to have diagnostic test. If she refuses, no problem. But there should be a sensitization of the gynecologist also, obstetrician.
Exactly.
Do you want to say something?
The terminology of non-invasive testing itself is wrong in my opinion. It is not NIPT, it is NIPS.
Yes.
It is not a testing, it is a screening method. And if you ask me anytime, if you give me an option, whenever I am doing a genetic counseling, patient comes either with a double marker high risk, patient comes with any of the ultrasound abnormalities also, my first option is to give the amniocentesis. If the patient is thinking 1,000 times, and nowadays people are reading up because they are screening this one and they are learning in Google or something, and they'll come, no, there is an NIPT screening test, we can do it across. But what will happen if an ultrasound abnormality is there and we do an NIPT, and if it misses across, we are losing a precious pregnancy across. That is something which is a scary part of the non-invasive prenatal screening when come. And NIPS is never going to be replacing the, many people say that it is a replacement of the prenatal diagnosis. No, it can never ever do it across also. And it can sometimes can be an alternative to the double marker or the quadruple marker. I can say there's an alternative, not even the replacement.
Absolutely.
Word. Both are different words.
Things. So if you have an NIPT, what Australian people have started is that do an ultrasound. If there is a single pregnancy, if it is a viable pregnancy, then rather than doing double marker and analyzing the risk, because whenever you do double marker, it is a human interference that you are taking the blood. You have to note the gestational age, that is CRL. And if there is any discrepancy, the software will say either low risk or high risk. So there is a human interference. Second thing, if I am not doing that test in my own center and sending the sample through courier, what is your take? Is there, because it is a very micro analyte, there might be some change during transport.
Temperature variation, so many things across comes into the picture.
With that, you are assessing a Down syndrome with what courier person is taking my sample correct or not.
Correct.
तो उसका जब रिपोर्ट आएगा, उस रिपोर्ट पे आपको नहीं मालूम कैसे करके वो गया कैसे, तो आप उससे एक रिस्क असेसमेंट करते हो. So what they have started, they are replacing the thing with NIPS. If it is a low risk, then negative predictive value is very good.
Good. Yes, exactly. Negative predictive value
is good. I think it is.
Yes.
I am correct.
Yes, sir. No doubt about it.
They actually calculated the risk, the cost effectiveness. They said कि अगर if we are doing NIPS for these many people, and then we are doing double marker and then going for diagnostic testing. So they found that doing IPS will be less, that will cost less
Cheaper,
for
lesser.
everybody rather than going for double marker and then providing them, because the chances of going into a diagnostic test was more.
Because when you look at the sensitivity of the double marker, it is around 70%. So 30% there would be a chances of high risk across, and you may end up. And when you see the overall positivity of invasive testing, this one is hardly 2%. So 28%, whatever the cases we are
We have
doing,
unnecessary done.
this one.
So what people are now doing in some European countries, they are not doing ultrasound and doing NIPT start as a primary screening, which personally I don't agree, because if there is a vanishing twin, if there is something which
Vanishing twin, or even if it is a twin pregnancy also, I don't recommend NIPS. Even if it is, because the thing is, first of all, it will not tell which twin is affected across. Again, you have to go for an invasive. So that is, and vanishing twin, the major problem is false positive. If there is a remnant, we usually say that according to the NIPT protocols, what it says is, if it's a vanishing twin, we have to wait 8 weeks till it gets over. Or else what will happen is, when we are extracting the DNA, part of the remnant DNA, whatever the remnant, whatever the material which got aborted in the stomach, if it comes, and again you will end up doing a invasive prenatal diagnostic testing.
So I think it is a long discussion, and I think another lecture I had today with Dr. Shweta Pathak.
There is another question I have, which I was surprisingly asked by a lot of people. Even I was surprised. So they were asking me that, is there any way genetically that they can have genetically good babies? Even I was surprised. I said, it's your product. I mean, it's your sperm, it's your ovum, the babies will be like you. But they were actually asking me, is there a way we can have a genetically good baby?
Yeah, see, genetically good baby can be defined in two terminologies. Many people say as a designer baby, that is a designer baby's concept is totally different. But genetically a good baby is, in the population, consider Indian population, which are the most common disease. अभी थैलेसीमिया हो सकता है, सिकल सेल एनीमिया हो सकता है, SMN हो सकता है, DMD हो सकता है. We can have a healthy child. We can screen for the male partner and the female partner, or the donor, if at all they are using. We really don't know if they are the carriers for these particular things, and they are absolutely not carriers of anything. And we can make the embryos genetically healthy baby according to that particular population. Like in India, the incidence is thalassemia and sickle cell anemia and SMN population is on very high rise across. And next comes with the muscular dystrophy. You screen it, make sure everything is fine, then you can transfer it across.
What is your question? What we are doing, you are also watching in our reproductive medicine, that now there are couple who are coming and asking me pre-pregnancy couple carrier screening. So that is the same thing what you asked. It doesn't mean you screen for thousands of diseases. It is about what is going on in population. Like in USA, Ashkenazis have a different screening method. So it is a carrier screening as an ethnic origin and as a population based. If you can screen, I think I am correct, no?
Exactly.
If you can screen those things.
One more thing.
Yeah.
They were also asking, like, people have diabetes, hypertension, heart disease. So is there any way we can actually detect that this particular child will have more risk of these diseases? Because this
No.
is also a major concern,
Okay.
which people quite ask.
See, whatever you are telling about the diabetes and higher hypertension, and another one thing, cardiac problems across. Now, all these, these are not following the Mendelian pattern of inheritance. These are the polygenic, this one. Although there are certain tests, what we say it as polygenic risk score across. In the embryos, we can say that this is a polygenic risk score, तो ताकि ये लोग को हाइपरटेंशन नहीं आएगा, नहीं तो डायबिटीज नहीं आएगा. Exactly, we can do it, but for Indian population, we need to have these are all SNP based, single nucleotide. We don't have single nucleotide polymorphism data for Indian ethnicity to come to that kind. In US and Australia, they are doing it across, but it is a test in form. They have selected these embryos and they have transferred, but these are all like adult onset, right? We have to wait for 20 years to whether they will be really getting it across.
So I am concluding this talk because it is at already 1 hour. जो what Ashita is asking, जो पूछ रही है, जो इनने एकदम एज ए जेनेटिसिस्ट बड़ा फास्ट बोल दिया SNP बेस्ड, तो जो ये SNP बेस्ड बोल रहे हैं, ये एक बेसिक पॉलीमॉर्फिज्म, एक बेसिक टाइप ऑफ DNA पैटर्न के साथ में वो डिजीज जुड़ा है कि नहीं, आपको पूरा पॉपुलेशन का टेस्ट करना पड़ेगा, तब जाके आप एक नतीजे पे पहुंचोगे कि ये वाली वेरिएशन से साथ में ये डिजीज चलती है, फिर उस वेरिएशन को देखोगे आप एम्ब्रियो में है कि नहीं. आई थिंक आई एम करेक्ट.
Exactly.
बट अगेन दीज आर ऑल यूजुअली नॉट डन, एंड इफ यू गोइंग टू डू दिस यू आर रिस्किंग अ बेबी. यदि वो बच्चा पैदा भी होता है तो पहले दिन से आप उसको बोलोगे तुम्हें ये होने वाला है.
We really don't know whether it will come or not.
And because it is a this is a multifactorial disease, multifactorial disease, तो कुछ हद तक हाइपरकोलेस्ट्रीमिया एंड जिसमें घर में हार्ट स्ट्रोक हो रहा है बहुत ज्यादा, तो कुछ हद तक there are things
certain mutations.
you can change your डाइट पैटर्न, लाइफस्टाइल पैटर्न. फिनाइलकीटोन्यूरिया का बेबी पैदा हो जाता है तो ऐसा नहीं है कि वो डेथ हो जाएगी, बट इफ यू नो प्रीवियसली देन you can prevent the complication. So this is a unending talk, and like अभी भी human embryo में disease को कट करके CRISPR Cas से edit करना still not ethical, and things उससे दूसरे implications क्या होंगे, दूसरे जीन, क्योंकि मल्टी जीन इफेक्ट करता है हर एक जीन को, तो वो अभी हम यहाँ पर वो बात नहीं करते, because it is a being with a geneticist, it is an unending talk. So I am closing this. I apologize for one lecture which we missed today. That is from Dr. Shweta Pathak. She will be talking in next journal club. She had a topic with thalassemia, because I was talking about genetic disease. So she was ready to talk on thalassemia, and because she is a hemato-oncologist for transplantation.
Yes, we can do the embryo matching, HLA matching with the transplant, and for the severe baby treatment, we can definitely.
So what I am not entering into that, because Sachin can talk on that.
Yes.
But मैं उसमें इसलिए नहीं जा रहा हूँ क्योंकि I will let her to speak in our next journal club. Thank you very much, Sachin, for with us. Thank you, Ashita, and thank you everyone. Please give your comments, कैसा आप लोग को लगता है, और यदि if doctors are listening to us, please comment करिए आपको कैसा लगता है. If you need more technical lectures, we can call multi faculty people, मैं बुलाता ही हूँ, और आपका यदि सहयोग रहेगा सबका तो हम इस जर्नल क्लब को और अच्छा बना लेंगे. Thank you very much for joining us.